We are going to start with Dr. Radhakrishnan, who is going to speak on Diagnostic Cath for congenital heart disease. As you know, the Diagnostic Cath for congenital heart disease has become very rare. Very rarely it is being done for diagnostic purpose in congenital heart disease nowadays. And most of the young cardiologists, when we were trained, we used to learn the cardiac catheterization by doing cardiac catheterization in congenital heart disease mainly. But nowadays, with the improvements in the imaging techniques and other modalities of diagnostic approach, the catheterization for this diagnostic purpose in congenital heart disease will come down very drastically. But in only a few certain indications, there are few certain indications where this cardiac catheterization is still being done for diagnostic purpose in congenital heart disease. Dr. Radhakrishnan is going to give you some tips and some indications for cardiac catheterization in children with congenital heart disease. Dr. Radhakrishnan.
I thought it was a very important slide, and the most important thing before we start doing a pediatric cardiac catheterization is proper planning. I'm not going into details of various techniques of catheter maneuvers, etc., because I'm going to restrict myself to the bare as to how we first started it and what is the current status now, what are the precautions that we take while doing a cardiac catheterization in order to minimize morbidity and mortality, because this is a definite problem when we deal with children with congenital heart disease. So planning is the key to the whole process. If you don't plan properly to each and every detail, then you're liable to get into trouble during this procedure. The question is, we have to answer these questions. Do we require to do a CAT study in a particular patient? What further information will I get over and above clinical evaluation, echo evaluation, CT, MRI? Am I going to further benefit by doing that? Is it going to help the surgeon by giving a cath data, or is it going to help me as an interventionalist first to do the cardiac catheterization, get the relevant information, and then go ahead with the catheterization? Do I have to do it under general anesthesia, under ketamine sedation, or no sedation? Do I have to do an oxygen study? Do I have to give adenosine, especially in patients in whom we have to evaluate for reversibility in pulmonary hypertension? Is angiography necessary? Is the angiography necessary before pressure study or after pressure study? The reason is angiography causes profound hemodynamic changes. So it is very important for us to understand that in certain situations we have to get the information before angiographic study. There are certain situations, for example, when we do a PDA closure, we quickly first define the anatomy of the PDA, do the measurements, because we don't want to cross the patent ductus arteriosus, and then might go ahead with the hemodynamic study to finally determine the hemodynamics. So these are questions which are important. In complex congenital heart disease, when we have to cross the subpulmonary outflow tract, we try to initially do it in a blind fashion, having an echo information. But when that is not possible, then we have to define a landmark of where the pulmonary artery is. Then we have to do a ventricular angiogram, define the subpulmonary outflow tract before we actually cross the subpulmonary outflow tract to get a pulmonary artery pressure. So these decisions are very important, whether we do an angiography first and then do the pressure study, or do we do the pressure study and then do the angiography. In the majority of cases, the principles are first take the pressure studies and then go ahead with the angiography, but we might have to change this. Do we require an anesthetist to be present during the procedure? There are certain situations where we might not do the procedure under general anesthesia, but we would require a standby in anticipation that some problems can occur during the procedure so that he is available with us. And what should be the vascular access? Where, what size of vessel, what size of sheath, where catheters, etc. have also got to be planned before we go ahead with the procedure. Why do we do all this? I'm sure the adult interventionist or the adult study also requires some of these planning. But in pediatric practice, it is so important because there is no doubt that there are greater morbidities associated with pediatric cardiac catheterization, especially as we start dealing with newborns, infants, etc., and small children. And these are certain unusual complications which we don't bother during adult practice in the majority of cases. Hypoxia while doing the procedure, If you don't keep on checking the blood gas frequently, then they might land into acidosis. And remember that acidosis has profound changes on hemodynamics. A small child or an infant or a newborn can become hypothermic if you don't take proper precautions. If a procedure is prolonged, sepsis can occur. Loss of blood can cause a dramatic fall in hemoglobin, which might have to be replaced later. Loss of pulses is such an important issue, especially in the newborn period and in infants, that you might end up with a completely successful procedure, but you might not be able to get proper pulses, in which means that this patient has to be heparinized for a longer time, and in extreme cases might have to be given streptokinase or thrombectomy, etc. has to be done in some cases. Fluid overload while in the procedure, especially if the procedure is prolonged, especially even a small thing like flushing with saline can cause fluid overload if it is a small baby. And actually, if the procedure is very prolonged, you can actually see that the baby gets swollen up during the procedure itself. You have a very limited volume of contrast available to perform your studies. Fortunately, now the imaging technique has become so refined that we hardly ever do any angiographic study in the newborn period, because all the anatomical details are available with us. So we have to restrict ourselves to get the relevant amount of information and minimize the contrast load related to angiography, or do no angiography at all. There are certain instances where we will just go and do the pressure studies, the hemodynamic studies, come out, and because we have already done the angiographic study and no additional information is going to be gathered by doing that. Please, before doing a cardiac catheterization, do a proper physical examination of the child. Ensure that there is no fever, no intercurrent infections going on, history of any recent exanthema which the baby has suffered from. Try to localize the focus of infection. Remember that a simple chest infection can have profound effect on hemodynamics. So there is a reason behind this. Of course, nobody catheterizes any patient with ongoing chest infection. That's besides the point. But then remember that chest infections can have profound effect on hemodynamics, pulmonary hemodynamics especially. Most of the studies which are done are to determine the pulmonary hemodynamics in most of the cases. Most of us would admit a child the evening before. Usually we don't resort to these day caths as in adult practice, because first of all they have to undergo a lot of blood tests. Most of it are routine, but if you are planning the general anesthesia, the anesthetists insist on getting an LFT done. We have to secure a good vascular access. This is not related to the vascular access during the hemodynamic study, but a vascular access prior to give proper sedation, whether it is local anesthesia, ketamine, or general anesthesia. So we have to have a very good vascular access which is stable. The baby has to remain 4 hours fasting. During this period, IV fluids are necessary. Usually we would give isolite P till 2 years of age, 100 ml per kilogram. Each center will have its own protocol, and ringer lactate about 50 to 60 ml kilogram before 2 years of age. We don't want the child to get dehydrated or be extremely hungry before the procedure. We generally give chloral hydrate, 50 milligram per kilogram, 1 hour before the procedure, and because we want the child to be sedated, and we don't want hemodynamics to be impaired in a very agitated child with a lot of tachycardia, and pre-sedation before actually giving ketamine or general anesthesia helps a lot. Sometimes very severely elevated hematocrits have to be dealt with before cath, may require bloodletting on the evening before the cath. Sometimes we might do it during the cath. Remember that these patients who have severely elevated hematocrits are usually adult with cyanotic congenital heart disease. But even then, it is better to plan the whole thing on the evening of the procedure rather than do it during the cath procedure. The advantage of doing it during the cath procedure is that we have large sheaths into the big arteries and veins, so that bloodletting can be much more easier than doing it through a small vein, a peripheral vein. As soon as we reach the cath lab, it is extremely important to have a checklist on reaching the cath lab in the morning. It is better to have the resident come early in the morning, because most of our cath procedures in children are done early in the morning. So I always tell my residents, please reach the cath lab half an hour before the procedure. Check everything, each and every detail, an appropriate site sheaths compatible wires, catheters, balloon, if we have the appropriate size, lengths, if we are going to use the coil, do we have the appropriate size coils and devices? I'm sure the adult practice also does this, but the disadvantage with that, our inventory in pediatric practice is so small. Most of the adult labs, you would see a whole lot of stents lying supplied by the company, so there is really no problem. Whereas in pediatric practice, we have to order most of the things a day before, especially balloons, coils, etc. So it is very important for you to check in the morning that the appropriate size coils or devices or the size, length, suddenly you realize that the company has not supplied a particular size of device which you are actually planning to use. It is very common in a country like ours, and you get into trouble with this. So it is better to check all this, and if these things are not available, it is actually better advisable not to do the procedure at that point of time. Always check pressure transducers. We always want to have 2 pressure channels available with us during the procedure. This is something which, the practice which has been completely given up in adult practice. Most of us are not concerned with 2 pressure channels, simultaneous pressure recordings, etc., etc. So our own lab, which is dedicated to the pediatric lab, has 2 pressure transducers, but it's very important in the morning to check that they are functional. A properly calibrated oximetry instrument, an echocardiography machine is a constant feature in most of the pediatric interventions. So please check that the echocardiographic machine reaches the lab before you start the procedure with or without a transesophageal echo. There are many instances when we have to switch off the AC temporarily in newborn or early infancy to prevent the child getting too much cool. Check that the ventilators are properly functioning. Usually that's the job of the respiratory technician, but then ensure that he comes and checks the ventilator machine each day before we start the procedure. The oximetry machine, it's a very important part of our cath lab. Every pediatric cath lab should have this machine. Unfortunately, surprisingly, it has become so difficult to procure. Remember that it is not the same as the blood gas machine, because the oxygen saturation that we measure from the blood gas machine, which is available in most of the hospitals, is a derived parameter, whereas oximetry machines actually measure saturations directly. And we insist that whenever we are doing an oximetry run, we should measure the oximetry saturation, we should measure the saturations by oximetry rather than the derived parameters from the blood gas. So all cath labs, doing pediatric cardiac catheterization on intervention should have this oximetry machine available in the lab. If you look at this figure here, that's the oximetry machine. It also measures the blood gas, but then it measures the saturations from a different format as the usual blood gases. We are all familiar with this. A continuous monitoring of the oxygen saturation is necessary during the procedure. It's a very crucial thing. So a pulse oximeter is a very important part of any pediatric cath lab procedure. Cath lab, the cardiac cath lab machine itself, most of the adult pediatric cath labs in very high centers across the West have a biplane machine, because it is preferable to have it because visualization of complex anatomy is made easier and less contrast load is necessary. Most of the cath labs which are available, I have not seen a biplane machine in this country for a long period. When we started training in cardiac catheterization, a lot of machines used to be biplane. But now we don't see biplane machines anymore, because most of the labs are actually tuned to adult interventions or adult procedures, and we actually piggyback on them. So I have not seen a biplane machine for a very long time. Many of the cath labs in the West have high-end labs which use rotational angiography with 3D reconstructions for accurate stent positioning in difficult cases, for example, coarctation stenting, etc., or pulmonary artery stenting, to actually get 3D images and plan your procedure very well. But in a practical term, most of us function with a single plane cath lab that is available for us. The cath procedure, it is always preferable to start the procedure early in the morning. The babies are less irritable and less hungry. We have to take a decision on ketamine sedation with a general anesthesia. That's a very important decision when we are planning the cath procedure. And our own policy is when we are intervening in newborn and infants, we prepare general anesthesia, because at least the airway is well controlled. We don't have to worry about that aspect. Very sick children, like for example, pulmonary stenosis with severe tricuspid regurgitation, patients having left ventricular or right ventricular dysfunction due to any reason, we would prefer general anesthesia. Any TE-guided procedure, of course, should have a general anesthesia, whether it's an adult or a small child. Diagnostic study. Now, remember that most of the diagnostic study are done in grown-up children. We hardly do any diagnostic study in newborn or infants. Usually, we do it with ketamine. Interventions in stable grown-up, for example, a 5-year-old child with valvular pulmonary stenosis without any heart failure would have the procedure done under ketamine anesthesia. Of course, we ensure that the anesthetist is around and available at a moment's notice. Sometimes we require large sheets to be put into the arteries. For example, coarctation of aorta when we start doing stenting, we prefer to do this whole procedure under general anesthesia because we have a control over the hemodynamics, especially in relation to bleeding after sheath removal. Of course, we have techniques to control bleeding like perclose, etc. Most of us are not familiar with this. We are still used to manual pressure. So, for an example, in a coax stenting, when we are using 14 French sheets, etc., we tell the anesthetist to lower the pressures to 100 or less temporarily for some time, control the bleeding, and do that. We would never be able to do this because the pain which is related to removal of sheath is so acute that the blood pressure shoots up and creates complication. Requirement, whenever there is a requirement for rapid ventricular pacing, it's a very unpleasant feeling. So, we would do the procedure under ketamine and then top it up with propofol during the process when it is pacing, so as to cut off the uncomfortable feeling that can be associated with very rapid ventricular pacing. So this is our own protocol that we follow. Ketamine sedation has its advantages. It produces minimum respiratory depression, except of course in the newborn period, usually doesn't cause hypotension. It has minimal effects on pulmonary hemodynamics, very rapid onset, and a relatively quick offset of sedation. Most of the time when we do ketamine sedation and do a procedure, we don't have to observe them in the ICU. We would shift them to the ward because the profile of the patient is such that they are usually grown up and they usually wake up by the time we secure hemostasis after the procedure, so they can be safely shifted to the ward. So that's because of the pharmacokinetics of the drug. There are, of course, disadvantages. It causes tachycardia, hypertension, and excess secretions. So the dosage schedule for us, what we follow is we would first give glycopyrrolate in order to eliminate excess secretion. We would give a ketamine bolus 1 to 2 milligram per kilogram IV, and very rarely we have to do this IM if you are not able to secure a good IV access, which happens extremely rarely, but it has happened with us. Then maintain on an infusion of 50 to 75 microgram per kilogram per minute. Usually this accounts to 0.6 ml into the body weight in ml per hour in a strength of 5 milligram per minute. We might give midazolam boluses if necessary in order to sedate the child further and cut down on the excess tachycardia that occurs, and may give additional boluses of ketamine of 1 to 2 ml in this strength if necessary during the procedure. Restraining of the child is extremely important. Of course, it is not necessary in general anesthesia. Remember that in the initial few minutes of ketamine bolus, it might be difficult to restrain the child because of the increased muscle tone associated with ketamine. It is extremely necessary in order to avoid excess movement during the vascular access and during the study. For angled views, the arms have to be placed above the head because the shoulder, etc., would intervene with a proper visualization of the anatomy. As soon as the baby is ketamine sedated, you have to connect it to the ECG, and a pulse ox is very important as soon as the baby comes into the cath lab after ketamine sedation. Expose and scrub both the groins. We are never sure which side one might be able to puncture. This is again a practice which is slightly different from the adult practice. We always expose the groin on both sides. Maintaining body temperature is an extremely important issue. Utmost importance, especially in newborn and infants. We can use simple techniques in the cath lab like covering the head, armpit, foot with cotton. Switch off the AC before the procedure till at least the baby is draped. The technician sometimes might not agree to this because he would protest because of the heating of the machine, but sometimes we have to do that. And of course, we have more sophisticated ways like using a bear hugger during the procedure. We might use that if the procedure is prolonged. Never use any radiant heaters or blowers near the patient. This was a practice which was done before, about a decade ago, but because remember that while you're doing the procedure, since the heaters and blowers are close to the child, it can cause burn. This is something which has happened with us before, so we have now eliminated that part of the step in order to maintain body temperature. These are some of the restrainers. I remember when we used to train, this used to be made of bakelite, but now we are doing it with wood, and these are various sizes of these restrainers, and this is how it works. It is placed in the cath lab. If you see, there is a piece of cloth which is here, kept here. I'll tell you what the reason behind this is. That if you remember, now if you look at these pictures, this child's hip has been placed over this towel. This is in order to bring the hip forward so that there is no depression, because all these small things can cause so much of difference in our vascular access. So it is better to bring the hip forward so that this portion of the groin is actually stretched forward, and that makes access to the vein and artery much more simpler. There is a cross here because this has been purposely done because we don't want the arm to be present by the side of the patient, unless of course we are not doing any angiography. But if we are going to do angled views or steep lateral views, the shoulder is going to invariably come and obstruct it. For example, when we do a PDA angiography, we do it on the lateral view, and definitely the shoulder is going to come on both sides and hamper proper viewing of the PDA. This is how we keep the arm outstretched up above the head, so that when we are doing angled views, the shoulder doesn't come and obstruct the view. This is a child under general anesthesia, the anesthesia equipment with a T in place. Boyle's trolley is a permanent fixture of our lab in a pediatric echo lab. In the pediatric cath lab, it is always present there. We don't have to move it from operation theaters or etc. in order to secure it. Both the vascular access has been taken or is being taken in order to minimize the procedure time. One can take an artery on one side, the vein on the other side. If this guy is lucky, then he might secure the artery and vein just before, much before this guy, or it can be the opposite way. He can do this before this, so you never know which way it works. Vascular access can be varied. We have transfemoral, transbrachial axillary, internal jugular, subclavian, transcarotid, transumbilical, transhepatic. All of this is being practiced, but I have made stars here in order to show the importance of the frequency in which it is used. Clearly, transfemoral predominates in most of our access. Internal jugular, especially in complex congenital heart disease, which have undergone specialized procedures like Glenn. Subclavian vein. Transcarotid is very rarely attempted. It is said that you can access the aortic valve or vertical PDA much better through a transcarotid access, but that requires a surgeon to be present because it cannot be done through a simple puncture. Transumbilical is usually during respirate measures when we are not able to, for example, balloon septostomy, when we are not able to secure vascular access. If the child is a day or two old, we can use the transumbilical technique, but this has become extremely rare. But we are doing it once in a while, probably once in a year. So one should be familiar with this approach. Most of the pediatricians are actually familiar with this approach. This is one of the disturbing factors of a pediatric catheterization. Arterial complications following cardiac catheterization, experience with iatrogenic pediatric vascular injury. So it is not insignificant. So one has to be very careful. One has to be extremely focused and be very careful. So the question is, do we need a sheath in the artery in this particular study? It is not necessary that we have to have an arterial sheath always. There are multiple factors which govern it. Is a left-sided angiography necessary? Do we need a pressure or saturation of the central aorta? We can always take a peripheral oxygen blood gas, but do we need it of a central aorta? For example, the ascending aorta or deep near the descending aorta. Do we need to have pressure study in the left ventricle? So all these factors govern whether we need to put in a sheath. If not, if a sheath is not necessary, don't do it in a routine fashion. Substitute the sheath for a cannula, either a radial or a femoral. If you require a femoral, if a radial is not accessible, then take a femoral in order to minimize the arterial injury. That is a very, very important step, because you might think that you're just putting a 4 French sheath, but at the end of the procedure, you might land up with an occluded artery and then start heparin and with its related morbidity. The size of the sheath should be smallest possible. We have sheaths available from 3 French to 6 French. These are pediatric sheaths which are compatible with an 021 guide wire, which means that it is compatible with smaller needles. We can have greater liberty with veins. We can put larger sheaths in the vein. You can always change the size of the sheath later so that a larger sheath in the vessel is there for the shortest period of time. I'll give you an example. When we are doing aortic valvuloplasty, we would start with a 4 French catheter in the artery, first cross the aortic valve, and then when the procedure comes to the balloon, which will require a larger sheath, we'll quickly change that sheath, because remember, the longer the sheath that is present in the artery or the vein, the higher the chances that it can cause occlusion. So one can change the size of the sheath later so that the larger sheath is in the vessel for the shortest period of time. Local anesthesia should be given with the smallest possible gauge needle. We don't want to injure the artery or the vein while giving the local anesthesia because it can produce hematoma. A minimal volume should be given in order to prevent distortion of landmarks, especially in newborn and children. You can easily distort the landmarks by even an extra 1 or 2 ml of volume of local anesthesia. And please wait for a local anesthesia, especially when the child is in ketamine sedation. Do not be in a hurry. Let the local anesthesia take effect, because if you cause pain, the child is going to become restless, he's going to wake up, then it creates a vicious circle. You are going to give more ketamine, you are going to give more midazolam, the child will get over-sedated, and all this will affect hemodynamics. So be patient, wait for the local anesthesia to take effect, and then go ahead with the access. The vascular access and needles that we have available, we have these 22 gauge cannula for newborn, 20 gauge cannula in infants and children. We sometimes use the Seldinger needle, especially for subclavian, jugular, carotid accesses. Carotid accesses most of the time by a surgeon, so we don't puncture carotid arteries. Most of it are 22 gauge. The length is about 4 centimeters. It's a shorter length, and they are all compatible with 021 wire. In grown-up and children, the length of the cannula sometimes might become insufficient. So this can be very frustrating that you might not access the vein, especially in a child who is a bit obese. Heparin, as soon as an arterial or a venous access is taken, 100 units per kilogram. If the procedure is prolonged, additional boluses can be given after checking the ACT during the procedure. What are difficult vascular access, or rather, when do we have difficult vascular access? Clearly, the most common cause is the newborn period. When there is no subcutaneous fat, as in malnourished children, sometimes vascular access becomes very difficult because the needle tends to slip without any subcutaneous fat. Too much of fat, of course, most of the adult people are familiar with this. It is less common, it is more so in adults. Sometimes you encounter multiple lymph nodes in the groin, and what happens is the needle starts slipping over the lymph nodes, and it can be a very frustrating experience sometimes. Remember that multiple attempts causes loss of landmarks, spasm of the artery, and that is why we always take an alternate groin access, because this helps, because if one side you have lots of landmark, you have another side to attempt. Access to vein or artery when it is not needed. Do not remove it. After you finish the procedure, do not remove it. It may serve as a landmark for other vessels, which means that if you're trying to hit an artery and you secure the vein, do not take off the access. Let the vein be, let the needle or the cannula or the wire be in the position of the vein so that you have a landmark in order to attempt the arterial puncture. So these are some of the tips that I usually give to my students. It is advisable to get vascular access with the cannula in place in the ICU in selected cases, especially in the newborn, before shifting to the cath lab. It saves the time in the lab, and therefore procedure time is lessened. It is not infrequent for many of pediatric catheterization to do a balloon septostomy in half a minute, but take about 1 hour to secure vascular access. So it is not uncommon even now. So if the child is in the ICU, we sometimes say that why don't we take the arterial and venous access in the ICU, where conditions are much more conducive. The baby is in the warmer. It doesn't have to be exposed to too much of hypothermia. But the disadvantage of getting a vascular access in the ICU is that it is a blind procedure. You don't have the advantage of imaging, especially when you are going into large veins and artery. restraining in the ICU might be difficult, and therefore access might be difficult. But if you can secure it in the ICU, there is nothing like it, so that the moment the baby is shifted, one can start the procedure immediately. These are some of the sheets that we are using. If you see, they are short sheets, short in length. It is compatible with an 021 guide wire, which is what we need. So it is available in 4 French, 5 French, and 6 French. Remember that the availability is very limited. It is not surprising suddenly the nurse comes and tells you, sir, we don't have a 5 French sheet, pediatric sheet available with us. Then you are becoming desperate. You start shouting at them as to why it is not available. So that is why it is very important when you come early in the morning just to check that these things are available. These are the cannulas that we use, a 22 gauge cannula and a 20 gauge cannula for arterial or venous access. This is the adult arterial cannula which we use because it has a greater length and therefore it has a much more secure position, especially in the femoral artery. We don't use it in the radial artery, but once we have got a femoral artery and we decide not to put a sheath, we always put this long arterial cannula because it is secure in position. It does not slip away while you are doing the procedure. What are the mistakes made in the vascular access? Always important to remember landmarks. The commonest mistake that is made is not being able to differentiate the groin crease from the inguinal ligament. The puncture should be made just below the inguinal ligament, not at the level of the groin crease. Mistaking the groin crease for the inguinal ligament results in low puncture, and what happens is, in spite of a good black flow, there is an inability to pass the guide wire. This, I think, is one of the most important reasons why sometimes guide wires cannot be passed, even though you get good black flow. So this is how we differentiate. If you see that this arrow is at the inguinal crease, but this arrow is actually at the inguinal ligament. So if you start puncturing at a lower level, you might definitely get a good backflow, but you may not be able to pass the guide wire, and that becomes a very frustrating experience sometimes, especially for beginners. The mistakes that are made in vascular access, remember that the vein and artery is just beneath the skin in small babies. Do not push the needle to its full length. There is really no need because the vein is just lying below the skin, almost below the skin. And sometimes, rarely, it has resulted in bladder puncture, especially if the bladder is full. Wait for oozing to settle after an inappropriate puncture. Especially, hematoma can result in complete loss of landmarks, especially in newborn babies. And remember that oozing might continue for a long time, especially in cyanotic babies and newborn. So be patient after an inappropriate puncture. Inability to pass wires. Usually, you're in a superficial vein. You're at a wrong angle. Sometimes it helps to gently press the tip of the cannula while passing the wire, and you suddenly find that the wire goes into the vein or the artery. Of course, the cannula is not fully in the lumen. A mistake that most of the beginners make when they are started doing pediatric catheterization is when the usual wire which is provided with the sheath does not pass, they immediately change over to a Terumo wire. Remember that Terumo wire is useless if your cannula is not properly in the vessel. There is no point in pushing a Terumo wire when you have not in a proper vein or it is not well in the lumen. Terumo wire is useful once your usual wire has already crossed it is already crossed over the iliac and it is getting distally obstructed. That is where one can change over to the Terumo wire so that you can cross over. Probably there are some valves there which prevents these usual wires to cross more distally. Mistakes in passing the sheath. Remember that the maximum resistance is at the skin and subcutaneous tissue, especially with previous punctures that have occurred. This results in kinking of the wire. So it is important to make a very small incision in the skin. Use a corkscrew motion while passing the sheath. Do not try to push the sheath because that can result in kinking of the wire and you might sometimes completely lose that appropriate vascular access. Sometimes it is useful to use the dilator first in order to make a tract and then load the dilator onto the sheath, and then it makes things much more simpler. Post-vascular access, immediately sampling of the artery for a blood gas is a very important factor with or without general anesthesia. Irrespective, remember, of the pulse oxygen saturation. Why? You have to know the status of oxygenation PO2. You have to know what the pH and PCO2 is, because besides morbidity, it has a profound effect on hemodynamics, which I had been discussing right from the beginning. Should also be checked in the middle of the procedure if it is prolonged. And always check again and again during the procedure, especially if the procedure is prolonged, and also after the procedure is over, in order to ensure that the baby is stable. There are some tips during catheterization. Be very gentle with the catheters, especially the so-called danger areas, the atria, the appendages, the right ventricular outflow tract. And there was an old dictum which was taught to us by our teachers that whenever you enter any chamber, do not try to pull it off, especially if you're not happy, if you think that you're not entered the proper chamber. Take the pressure, the saturation, think about an angiogram. It is possible that you might never be able to enter that chamber again. So it is always important, and this is what, it might not be applicable in today's practice of pediatric cardiology, but always remember this dictum which our teachers taught us. Some tips during catheterization. Common difficulties for beginners: mistaking the right atrial appendage for a left atrium and trying to push the catheter forward in order to go deeper into the left atrium. And this is something which I have to point almost every day to my students. I keep on warning them, look, the place where you are pushing is the right atrial appendage, it is not the left atrium, because sometimes the right atrial appendage overlaps the spine and can cross over to the left side and easily give a confusion that you're in the left atrium. You tend to push it and you might perforate the right atrial appendage. Not understanding the landmarks of the pulmonary vein entry, most of us what we do is we go right down to the left side heart border, that is where we are at the left atrium, and then try to enter the pulmonary vein. Remember that the pulmonary veins have already entered the left atrium much before the left heart border. So that is one common mistake which is already made, and invariably you will fail to enter the pulmonary vein. SVC entry can sometimes be extremely frustrating for a beginner. The catheter keeps on bending, and so sometimes you might have to resort to the use of a wire to enter the SVC when you enter with the catheter. Right ventricle to pulmonary artery, the catheter tip many times is too lateral during the maneuver, that is along the left heart border. Remember that the right ventricular outflow tract is always medial as compared to what you see on the X-ray of the left heart border. So see, these are some of the tips which for a beginner becomes very important. Post-cath, it is common to remove all the sheaths in the cath lab. We do that most of the time. But remember that we want to retain the anterior arterial cannula if the procedure is done under general anesthesia till the child is fully extubated, or even beyond after extubation, or if trouble is anticipated without general anesthesia. So please don't be in a hurry to remove the arterial cannula. Be in a hurry to remove the arterial sheath, but not the cannula. Let it be there. Let the baby stabilize fully. Take blood gases in between to ensure that the baby is properly oxygenated, and then only once you feel that the baby is stable, you can remove the arterial cannula, because in the majority of cases, arterial cannula is not going to cause any harm to the artery. If the arterial monitoring is necessary, one can remove the sheath from the artery and then insert an arterial cannula in a radial, rarely on a brachial or a femoral artery. This can be done because your whole procedure, while it is being done, you have the pressures from the radial sheath or from the femoral sheath, but then you want to remove the sheath, so you tell the anesthetist to secure a brachial radial artery cannula so that the pressures can be monitored in the ICU and sometimes beyond. Extubation for general anesthesia patients. Multiple factors govern this: hemodynamic stability, the duration of the procedure, the pressure of the cath lab timing is very important, and availability of ventilators in the ICU. All these govern whether you are going to ventilate the child, continue to ventilate the child, or you are going to extubate the child in the cath lab. But as a principle, we rarely extubate in cath labs in newborn infants and children. We don't prefer to do that because then we have no control over the oxygenation or ventilation of the child. We always prefer to shift the child to the ICU where it can be done under much more stable condition. As an example, for example, in an adult who has undergone an AST device, our practice is to do it under general anesthesia and T guidance. One might prefer to extubate the adult in the cath lab itself, so that we have no problems in shifting the patient to the ICU under ventilator. So these are all some of the practices which are done in our center. Post-cath, all newborn and infants, post-GA, unstable patients should be shifted to the ICU. Newborn and infant should always be shifted in a warmer. Don't just shift the child in a large bed because then the child might cool while shifting. Watch for pulses and hematoma at the access site even after shifting the patient. Our policy for absent pulses and venous congestion is common in newborn. The easy solution is to elevate the leg, may require heparin. Loss of arterial pulses is very disturbing. We wait for half an hour. If there is no pulse, we would give a bolus of heparin, which is followed by an infusion for at least 48 hours, and then take a decision whether we have to do an embolectomy or give streptokinase. Usually, we monitor the pulses manually by Doppler, look at the limb worm, and of course, as I said, we continue heparin. One of the things which I teach my students is to have what I call as a roving eye during catheterization. Please keep your eyes all over the place. Look at the monitor. While you are doing the catheterization, look at the monitor, the rhythm, the rate, look at the saturations, look at the pressure. Keep on looking at the pressure while doing. Don't be blind to what is happening around you. Look at the pressure, whether it is increasing or whether it is decreasing. One of the most important signs of a baby waking up is it causes tachycardia and the pressures go up. This might be the most subtle sign, and you can warn the anesthetist, look, I don't want this to happen because it is going to hamper my hemodynamics, so please go on to a deeper sedation. Look at the fluoroscopy. Don't just look at the heart and the catheter position. Look at for collapse, pneumothorax, tamponade. All this should be looked at, so you have to have what is known as a roving eye. This was an example which happened to me. You can see that this patient has a T in position, has a general anesthesia, an intubated patient, and you can see that the whole of the left lung and the right upper lobe is collapsed. Why? Because you see that the endotracheal tube has been pushed deep into the right lower bronchus, and it is you who has to point out, because the anesthetist is completely unaware after doing this, this has happened. This is another example. While you are doing the procedure, if you have a peripheral arterial cannula, in between you notice that the arterial pressure gets damped. If you're not careful about this, you might actually completely lose this artery. It can be completely blocked, and this can be extremely frustrating experience if you are dependent upon the arterial cannula to give you the arterial pressures. So keep on flushing in between. Keep on looking at the monitor, because most of the time the anesthetist is not looking at it. So it is your job to look at it. So I call this a roving eye. Keep your eyes all over the lab, not only to the heart or to the monitor or to the fluoroscopy machine. Thank you very much.